The following podcast is part of a certified educational activity titled Mastering Multidirectional Tactics in HCC, Expert Guidance on Emerging Trends with Systemic Therapy Options Across the Disease Continuum. Access the entire activity and complete the post-test at peerview.com/VXT860. Downloadable slides and practice aids are also available.
Good evening, everybody. A very warm welcome to Mastering Multidirectional Tactics in HCC. Complex title. It means we have more options for our patients, which is good for our patients, and that requires thinking and decision-making, and that is what we are going to talk about tonight. Then it's my great privilege to be joined by Lipika Goya from Stanford and by Stacy Stein from Yale, two experts in the field of hepatocellular carcinoma, so the three of us should make it. I'm Peter Galle from Mainz University Medical Center in Germany. I'm a hepatologist and feel I like the oncological support. For those of you who are not familiar with Blue Faery, it's an association around for 20 years and is trying to prevent, treat, and cure primary liver cancer. And it's relevant not only for physicians, not only for patients, but also creating the informational background for clinical trials and spreading liver cancer news. So it's an important organization, and I encourage you to go on their homepage and to support Blue Faery. Yeah, our goals today, we want to give the evidence which has been generated for the most part with respect to systemic therapy. And that will be based on individual patient characteristics which we are modifying. We will try to give you some flavor how to make decisions and how to develop strategies in the interdisciplinary situation of patients with hepatocellular carcinoma. And as a reminder, it starts maybe with systemic therapy, and there are options from surgery, including liver transplantation, which makes it quite complex. I'd like to give you a small introduction into the field of hepatocellular carcinoma. When I went to medical school, it was an important tumor, yeah, but a tumor you didn't see in your country. And that really has changed. Hepatocellular carcinoma is relevant also in developed countries in the Western world, and it has always been an important tumor. Almost 1 million patients are diagnosed per year, and the majority of them will die. So it's a tumor with a high mortality rate, and that defines a clearly unmet medical need. It has, throughout the years, ranking in the top 3 or 4 causes of cancer-related death. And what we expect is an increase, actually. And this is due to the fact that metabolic syndrome and with respect to the liver, it is the fatty liver disease and the steatotic inflammation, which in the end will result in a dramatic increase of liver cancer patients. And interestingly, this is not only related to those with liver cirrhosis, but may happen at an earlier stage of liver disease. We have developed over the years a complex staging system. The most widely used is the BCLC staging system, which is going from early stage to advanced stage and gives a flow chart, and on the left it offers curative intent treatments, and on the right systemic therapy. And systemic therapy in particular, that's something which 25 years ago, when AASLD coined guidelines, was not existing, and basically clinical trials were suggested. But in 2007, the SHARP trial entered the stage, and we learned that HCC is a systemically treatable disease. It was a rough time then for the next 10 years. Many negative trials, But in recent years, we have seen quite a few trials, and we will touch upon those, including, of course, immune oncological agents, which are playing a major role both with respect to efficacy and also to tolerability for the best of our patients. So we need to be aware that although there has been tremendous progress and our systemic armamentarium has increasingly been developed, but in reality, and that actually reminds me of the situation with respect to hepatitis B or C treatment. The issue is not just to develop new substances which are effective, but to bring them to the patient. And it's a reality that patients do not get the optimal therapy in many cases. And so in the end, many patients go untreated. And that is something which we need to change by awareness, public awareness, but also in our hands as physicians to be aware that we can offer these patients something to improve. At that point, I'd like to hand over to Dr. Goyal. Lipika will talk about the current status and emerging systemic therapeutic options in the frontline setting, a developing field. Lipika.
Thank you very much, Peter. Thank you to PeerView for inviting us all here and for all of you spending your Sunday night of ASCO with us. I feel very lucky to be here with Stacy and Peter to get their expertise. We certainly, as an oncologist, I phone a friend to our hepatologists at Stanford all the time to ask, okay, this is what we see on EGD with the varices, what should I do? Or this is what we see in terms of the cirrhosis, and I'm having trouble managing it, can you help us? So definitely it's a multidisciplinary effort to take care of these patients. And so I thought to engage everyone, we would start with a case, as always, because patients are the reason why we're doing all of this. So we have a 66-year-old woman with chronic hepatitis B, and she presented with right upper quadrant pain. We often get an ultrasound when we see this, and the patient had a liver mass. You can see the patient had relatively preserved liver function in terms of her bilirubin and her albumin and her INR, but you can see her platelets were low at 90K, good performance status. Her MRI showed a 7-centimeter liver lesion in the right lobe and some satellite nodules. She did not have any invasion into her portal veins or any extrahepatic disease in the lungs or the bones like we sometimes see with HCC. The patient had BCLC stage B disease, went on to have TACE, and then at the next scan, the repeat MRI showed multifocal bilobar progression with an increase in the dominant lesion. So the spot that was TACed, it grew from 7 centimeters to 8 centimeters, and she had 2 new left lobe lesions, 3 centimeters and 2 centimeters. So liver function remained good with Child-Pugh. So I'll throw it out to Peter and Stacy. When you see a patient like this, do you think about repeating TACE or Y90 or moving to radiation, or do you think of moving to systemic therapy?
How many TACE procedures have been performed?
She just had one, but she did have growth in the TACE lesion per scan.
So that has been one of the interesting discussions, how to TACE and how often to TACE. TACE is, in the end, a very individual procedure. If there is a nice feeding artery and a well-circumscribed nodule, then it's easy. If it's a diffuse tumor, if it's very large, and if the contrast agent is going everywhere but not in the nodule, then it's the wrong patient. On average, we would recommend 2 procedures, but this is actually a bit of gut feeling, yeah? How do you do it, Stacy?
Yeah, so, I think it really depends, right, on the timing. And in this case, given that it was such a short interval with growth in that tumor and new areas, I think even my IR colleagues would agree maybe it's time to move on to systemic therapy, which has only been in the last few years, right, where we had better treatment options that I think everyone felt like, well, maybe this is a time to give someone a chance to see if they respond to immune therapy. And, as the title to this program said, right, multidirectionality, we could always reconsider other things later, but maybe this, I think most people would say, maybe this is the time to make a change.
You touched upon a very important point, and that is that TACE is not just a procedure which is therapeutic, but it also offers a test of time. If you do TACE and the patient is progressing, then it's definitely not the right patient for example, liver transplantation, and maybe not for a repeated TACE, as you were pointing out. So we have to watch and to individually decide what to do with the patient. And a rapid progressor, high AFP, increasing AFP, these are all hallmarks of poor prognosis, and you should do something else. What about immune therapy?
I agree. Let's get on to that. I would just want to highlight one more great point that Stacy made, which is we're passing the ball from IR to med-onc, but then we often pass it back to IR. And it's not one direction, as Stacy was saying. We often represent patients at tumor board, and it's about who goes when at different times, but it's not linear from IR to med-onc to hospice. We often go back and forth. So let's talk about immunotherapy. Peter reviewed the BCLC algorithm about how we have different stages. And when people have advanced disease, so they either have BCLC stage B disease, that's refractory to liver-directed therapies, or they have BCLC stage C disease, which means that they have portal vein thrombosis or some sort of vascular invasion and or extrahepatic spread. And then also performance status can factor into BCLC stage, but generally speaking, we think of it more on those tumor factors. So we have a couple of options now. So let's move to what are the first line options. So as Peter asked, what about immunotherapy? So for anyone who is a candidate for immunotherapy, we think about doublet treatments, atezolizumab plus bevacizumab or durvalumab plus tremelimumab. If someone is not a candidate for combination therapy, then I often think about single agent therapies like durvalumab or tislelizumab.
Can I ask you a simple question?
Sure.
Who is a candidate for monotherapy, IO, but not a candidate for doublet?
Yeah, that's a great question. From my end, generally speaking, people who I worry about managing toxicities in them. So I feel like sometimes older, frailer patients who I worry that if they get immune-related adverse events and they're going to need high-dose steroids for significant colitis, significant pneumonitis, etc., or if I'm worried about they're going to have significant bleeding. So people who are often older, frailer for some reason, someone who's like someone who has Child-Pugh B7 or even maybe B8, I might still consider doublet, even though those patients were not included in the trials. But certainly more like the B8, B9 patients, I also think about a single agent. How about yourself?
I would just say I have a lot of patients who may be a little bit less compensated. If they're candidates for Atezo-Bev, I would give it, but we're going to get some more data. When you think about the steroid use of 20% with adding tremelimumab, I would say it's the patients who are not candidates for bevacizumab, and I think that 20% risk is too high for that patient. That's when I would think of the single agent.
Yeah, the pity is that we can't tell upfront who is going to react in what way.
Right.
And on the other hand, we saw when in the old days when we only had nivolumab or pembrolizumab, there were some fantastic responses in individual patients. So it is active, but not in everybody. And the doublet is better. So it's difficult.
And it really gets to another point we're going to talk about later is the biomarker selection for patients. If you can get away with single agent, that's ideal. And then who are the patients where you need to add either a CTLA-4 antibody or a VEGF antibody?
Not to talk about financial toxicity.
Yeah, exactly. Indeed, both for the patient and for the healthcare system overall. So luckily for people who are not candidates for immunotherapy, we also have options. So lenvatinib and sorafenib have been around for a while, and we're grateful we have those options. Stacy, in terms of people who are not candidates for immunotherapy, if someone has rheumatoid arthritis or ulcerative colitis, do you automatically rule them out, or how do you figure out when someone has an autoimmune disorder? It's always a challenging clinic.
No, I think that's a good question, right? When we say not a candidate, who is that population? And I think things have evolved over time, to kind of try to be more inclusive for immune therapy. I would say the one group that I guess I've always put in the category of not a candidate are the patients who had prior liver transplant, although I know even that could be a controversial topic to discuss, but I would just say I personally have not treated any of those patients with immune therapy. I have had patients with different autoimmune disorders who sometimes really said, I'm not on medication now and I really want to try this. I had a patient with multiple sclerosis who I wanted to put on lenvatinib, and he made me call his neurologist, and he said, I want to try this. I understand the risk. And the neurologist said, let's do it. And then he actually had autoimmune hemolytic anemia when I treated him, which I don't know if having the MS put him more at risk for another autoimmune condition, but I said, I think we're done. After we tried it. But I think it is tough. I think when patients are on active treatment for the autoimmune disorder, it's hard to argue that it's going to be a good idea to try. But I think some people with more of a remote history, and especially some of the skin conditions, if the dermatologist feels like they've been well controlled and it takes up only a certain percentage of skin, I think then we could push the envelope more. But I think especially people, let's say with ulcerative colitis who are on active medication, I think that's a big risk. And I personally would think this is a group not to give it to.
Yeah. I do something similar. I will call the specialist for whatever disorder that is and like collaborate and see, can we do this? And then I think, as you're saying, we've become more comfortable as a community using the anti-TNF alpha agents, using Mendoza to just figure out, like, can we actually get people through this? Peter, any thoughts from your end? I sometimes call my friendly neighborhood hepatologist or gastroenterologist when someone has autoimmune hepatitis or UC.
Well, the good thing is that most immune-related adverse events are well treatable and resolve. So we are actually not so afraid. And I mean, you have to be fair to the patient, tell the patient what may happen. But if you interfere and you really pay attention to our in close contact to the patient, I would say it's handleable. And I mean, the true game changer when you think about the old days with sorafenib, where these patients were sitting in front of your oncology clinics and they had these skin signs and they were very fatigued, that is definitely gone. Patients do so much better. And we will touch upon patient-reported outcomes later. So in essence, I would rather be inclined to tell the patient, let's give it a try. It's offering so much more, and we can probably handle it well if it doesn't work.
Totally agree. And in my experience, most patients want to go for it. So I'll mainly focus on atezolizumab and durvalumab, mainly because we're hitting home runs with these drugs, as opposed to with the TKIs, which certainly have a role in HCC, and we're lucky to have them. But because of the immune response to the immunotherapies, we're sometimes hitting home runs. So I'll mainly focus on these two regimens. And the way I thought I would go through this is go over briefly the schema for the IMbrave 150 study for atezo-bev, the schema for the Himalaya study with durvalumab, briefly go over the efficacy, and then start to point out some of the differences in the trials, because I think where we all are as a field right now is trying to choose which are the best patients for which therapy. And potentially on Tuesday, when we see the data for Checkmate 9DW, maybe there'll be even another regimen that we can consider in the front line. But I think understanding the nuances of these trials is where we're all, as Peter started this whole program with, we're all trying to think together and make decisions. So as many people know, for the atezolizumab bevacizumab study, it was the combination versus sorafenib in a 2-to-1 randomization. The population was slightly different for this trial compared to Himalaya. Both trials had locally advanced or metastatic and or unresectable HCC patients. Both studies were frontline studies with no prior HCC. This trial required an EGD within 6 months, and both trials involved patients with Child-Pugh A. This had about 480 patients. So co-primary endpoint of PFS and OS. For the Himalaya study, overall, some of the key differences in this study was that this study excluded patients with main portal vein thrombosis, which is different than the IMbrave 150 study. This study excluded patients with GI bleeding within the last 12 months, but did not require people getting an EGD. This is a larger study with about 1,200 patients, and there were 3 arms in the end: Durva alone, durvalumab with the STRIDE regimen, which is 1 dose of high-dose tremi at 300 milligrams with cycle 1. And then you do the combination to start with, and then durvalumab alone every 4 weeks, and then compared to sorafenib. Primary endpoint was OS, and the main comparison here was between durvalumab and sorafenib. And so here's the main efficacy data. You can see with atezo-bev, 9.2-month median overall survival. With sorafenib, was 13.4. With durvalumab, you see at 16.4 compared to sorafenib, 13.8.
Can I ask a simple question? Why is the IM Brave 150 Kaplan-Meier curves, why are they separating early and the Himalaya late?
Yeah, I have some thoughts about that. How about you, Stacy?
Well, I think it gets to the mechanism of action of the bevacizumab versus the CTLA-4 antibody, right? And so when it's all coming from the immune system, I think it's just, right, it takes a little bit longer average time. And I think we're still understanding the interplay between bevacizumab and immune therapy, which I think there's a slide I have later on, and we could look at that, but I think it just gives the time to response is just faster.
Has this shape of the curve consequences? Do we, for example, take atezo-bev, particularly for those patients where we want to see a quick response because there may be a nodule interfering with perfusion or something like that?
That's a great question. Does tumor burden and symptoms impact whether we choose atezo-bev or durva-tremi? I think it's one of many factors that we consider, so it's certainly part of the calculus. So these studies were not done as head-to-head, so you cannot exactly compare atezo-bev to durva-tremi. I just say that right up front. So there are caveats to cross-trial comparison. I'm putting all the data on one slide so we can just look at it all together, but of course we'll also go into the table ones in terms of what the populations were, et cetera. So we talked about the median overall survival data. You can see for the median progression-free survival, it wasn't that different in the Himalaya study between durva-tremi and sorafenib because the benefit was seen later. With the IM Brave study, we saw a median PFS of about 7 months. You can see the response rates of around 30% with atezo-bev, 20% with durva-tremi, and 17% with durva. And then a key thing here is the median duration of response. You see 18 months with IM Brave, 22 months with durva-tremi, and 17 months with durva. So let's dig into these studies a little bit. So a couple of things, as I mentioned with the atezo-bev, is that it required an EGD. And in your experience, Peter and Stacy, how long does it take to get an EGD? And do you think that could have impacted the kinds of patients that ended up going on the study?
That's one of the questions I never understood. It takes me a day. I mean, if I want to have a EGD, the patient gets it tomorrow.
To be a hepatologist.
Yeah. And in my country, in Germany, it's actually cheap. It's 70 euros or something like that. So this is not a limitation. And in addition, we scope liver patients anyway because we want to know whether there are varices. And if there are varices, we are able to treat them. So this is it might be different in different countries, but I think from the hepatological point of view, liver patients need to be scoped, and that on a regular basis. Of course, there are parameters such as spleen size, thrombocytes, platelets, which help you whether you do it frequently or not, but you do it.
So
how long does it take for you to get one? I would just say the caveat is,
I've done some community events where I do get the sense that depending on where people practice, right, academic versus community, rural versus closer to, that I do think that there are some places where they do have difficulty getting the EGD. And so I don't want to gloss over that it may not be an issue. But I will just say personally, I had a couple of patients on the phase 1 study have complete responses, and I brought back every scan to my tumor board, and I got the hepatologist so excited. One hepatologist was saying, "Unleash the T," because it was on one of the slides. And so I get an EGD whenever I want very quickly because they want the patients to go on study or on treatment as soon as possible. But I know that that's not necessarily the case everywhere. So I think for some places it becomes a consideration.
Yeah, I think it speaks again to the multidisciplinary nature of having good relations between oncology and hepatology and GI in general. I would say, luckily at Stanford, we've been able to get them very quickly, but I've also heard similarly at some places it's hard to get it quickly. And so I think that's one question about the atezo-bev study, that was it a slightly healthier group of patients on that one piece because people who were going to take 2 or 3 weeks to get an EGD, they were not included in this study. So the people who had very aggressive disease in that respect could have impacted the primary population. But they did also include patients with main portal vein thrombosis, which was not included in the Himalaya study. And those patients, as we know, tend to do poorer. So in that way, it had a more aggressive population of patients. Another key point that was different between these two studies was the stratification factors. For this study, it was region, baseline AFP, ECOG performance status, and then patients having either macrovascular invasion or extrahepatic spread. When you look at the Himalaya study, the stratification factors also included etiology of liver disease. So when we look at the baseline characteristics, you'll see differences in the percentage of patients that have had hepatitis B. And this study, because it didn't require an EGD, patients went on potentially more quickly. But again, they excluded patients with main PVT. So let's take a look at the baseline characteristics in these two studies. You can see on many different characteristics, they were quite similar, but there are a couple that they were different on. So for macular vascular invasion, at least numerically, these are not statistics, but numerically, the patients with the Atezo-Bev study, a higher percentage of patients had macrovascular invasion and extrahepatic spread. 15% of patients, which is quite a high percentage of patients, had main portal vein thrombosis. And again, those patients have poorer prognosis overall. But then you also look at the hepatitis B population, which tends to do better with immunotherapy. And it was about 50% to 30%. And again, in the Himalaya study, it was a stratification factor, so it was more even across hepatitis B, hepatitis C, and non-viral. But that could be a factor. And then also in terms of prior local therapy in the Atezo-Bev study, these patients were more heavily pretreated. They had livers that had more liver-directed therapy compared to the STRIDE regimen, compared to Himalaya, where 12% of patients had prior local therapy. So, Peter, when you look at these stats, does it make you think at all differently about the baseline populations?
I think it's very important to realize that there are differences amongst these trials. And I think the main issue here is main portal vein thrombosis. In that, there were no variceal bleedings in the Himalaya trial, but not coming as a surprise, because if the portal vein is patent, that helps, yeah. So we should know that, but as you were rightly saying, it's so tough to compare trial with trial, and it's food for thoughts and shows that there are differences, but it doesn't, I think in clinical reality, and that's the point, it doesn't help to make decisions.
Okay, so I want to share something about portal vein thrombosis, that there's a distinction between two different types of VP4. We know that VP1 is a third-order branch in terms of a blood clot, a tumor clot in a third-order branch. VP2 is a second-order branch. VP3 is when you have the right portal vein or the left portal vein involved. And then there are two different definitions of VP4. You can either have both the right and left portal vein involved. That's what you see on the left. Or you could have the main portal vein involved, and that's what you see on the right. So in Himalaya, it wasn't all VP4 patients that were excluded. It was only patients with main portal vein thrombosis, but the patients who have contralateral first-order branch involvement, that's also a high-risk population. So that's just an important distinction. And so the team that did IM-Brave 150 did an analysis of patients who had VP4 disease. This includes both definitions of VP4. And you can see that the median survival in patients with main portal vein thrombosis had a median survival of around 7 to 8 months compared to sorafenib that was 5.5 months. And remember, in the overall study, it was about 19 months. So this certainly pulled down the median overall survival. You can see on the right, if you took out the patients without VP4, the median overall survival was up to 21 months. But the response rate in patients with main portal vein thrombosis was actually 23%. So that was pretty encouraging. And so I think that these patients certainly potentially got benefit from this regimen, but there was a higher rate of bleeding, and majority of the patients who had significant bleeding were patients with VP4 disease. And then another key thing to point out between these two studies is the rate of systemic corticosteroid use. So as Stacy was pointing out earlier, in the Himalaya study, 20% of patients required high-dose steroids to manage immune-related adverse events. In the IM-Brave 150 study, it was similar to what you see with single-agent PD-1 inhibitors and PD-L1 inhibitors. You saw 12.2% of patients, and the people who got atezolizumab went on to get steroids. And so, Stacy, how does this impact your choice in terms of how you think people are going to be able to handle immune-related adverse events. Does it impact if they live far, if they don't live far, if they have family members that are going to call you or not? Like, how does that impact things?
Yeah. It's always a challenge when people don't have good support because you worry that they're going to not feel well at home and not call. Fortunately, I have to say most people tolerate this regimen well, and we'll talk a little bit more about the patient-reported outcomes later. But, fortunately, most people are not needing to call in between. We try to educate patients about different side effects to look for. It's always nice when we could identify someone who lives with them or is going to be coming over regularly to also be looking for these side effects to call. I try, though, to not limit patients' treatment options because I'm kind of worried from the start that they don't have enough support. I feel like we just try to add the support on with some extra phone calls or maybe some services of visiting nurse, but try not to change the treatment up front and at least give it a chance.
Your doctor?
It is handleable. That's my basic point. I was, when that story started, a bit concerned that steroids would interfere with the efficacy of therapy. That doesn't seem to be the case as far as we know, and contrasts to, for example, brain tumors, where it makes a difference if you have seen high-dose steroids. But for the time being, it apparently is the way to control the side effects, and then, side effects typically occur relatively early, within the first 2 to 3 months, and once you are through, that's it. So I'm not so much afraid of that situation, but traveling a distance, regular contact, that might make in Australia. If you travel a day to get to your doctor, it's not this scheme to use. Yeah.
Yeah, I think as all of us have gained more experience, there's less fear, and we're able to push the envelope a little bit more. And so these are the data in terms of the safety considerations. I know one thing we think about is what people's bleeding risk is. And so luckily on the IAMBRAVE 150 study, with excluding patients who had varices on EGD or significant varices on EGD, there wasn't a significant difference in the grade 3, grade 4 bleeding between the patients who got bevacizumab versus that got sorafenib.
Yeah, I'd like to highlight that because it was, in a way, you need to scope, but it was very liberally handled. You could do what you want, beta blocker or ligation, and it was just the local standard. And local standards differ, but it was sufficient. So it's not an extremely high bleeding risk. Most bleeds were minor bleeds. Yeah.
Yes, absolutely. I'm going to call upon you when we do the case to ask more about varices and how we think about those. Okay, so a couple of things to think about between these two studies. There's chemotherapy, targeted therapy, and immunotherapy in terms of the 3 kinds of systemic therapy we think about that are anti-cancer. And what's the difference between these 3 buckets? So chemotherapy and targeted therapy, they directly target tumor cells, versus immunotherapy, it boosts your immune system to be able to recognize your cancer as foreign. So the way they work in terms of long-term benefits is going to be different. And so that's been the big game changer with immunotherapy, that we see this tail on the curve. And so for a long time in cancer, median overall survival has been the gold standard. And I think a question in the field now is, should we be doing landmark analyses and looking at the tail on the curve, and should that be informing the way we make choices? So with the Himalaya study, they did a 48-month landmark analysis, and you see that the benefit is durable with the addition of tremelimumab, with 25% of patients with advanced HCC being alive at 4 years, which seems like relatively unheard of. Partly, we have not done this kind of analysis, but still, that's pretty remarkable. So, Peter, when you look at this, looking back on the last 30 years of looking at cancer data, do you think we should be thinking about landmark analyses more now that we have immunotherapy, or is median overall survival still your gold standard?
I believe that this landmark analysis is meaningful, and the proportion of patients having a long-term benefit is relevant. It's actually sort of interesting. We have seen, for the majority of the trials, 4 single-agent investigations: nivo, pembro, tislelizumab, and durvalumab. If you check the results, they're actually extremely similar. They're quite comparable. But because of trial design, 2 trials, Pembro and Nivo, were negative. And Tisle was non-inferiority, was positive, and Dova was also non-inferior. So it tells you that we should be critical about our trial design and the predefined endpoints. They decide in the end whether it's a positive or negative trial, although in these 4 trials, the data are exactly the same. So it's not so simple that you can say, oh, great, positive trial, median overall survival, good. No, it's more complex. And I think this interpretation is allowed to say we have a benefit which develops late, but is maintained long. This is relevant for the patient. Unfortunately, we can't separate. I mean, we would need to have the upfront information who is going to respond or not. Then it would be so much easier. Because in the beginning, you lose patients. That's clear.
Yeah, indeed. I agree with you. So before we move on to the case, we'll just mention a couple more studies. So one is the CARES 310 study with camrelizumab and rivoceranib. And rivoceranib was originally called apatinib. This was a study that was done in 13 countries, and it was a positive study. And you can see here that the median overall survival was 22 months, and there was just updated data here at ASCO 2024, which increased that by about a month. Compared to sorafenib, which was 15 months. And there was a decent amount of grade 3 or 4 AEs. Rivoceranib is a very potent VEGFR2 inhibitor, I think a stronger inhibitor of that pathway than bevacizumab and lenvatinib. And so that could account for some of the significant AEs that we see. So this just went up for consideration with the FDA, and the FDA has postponed decisions around it due to some manufacturing issues. And then this study, we're very honored to have Peter here talking to us today. He is going to be presenting the data for Checkmate 9DW on Tuesday, which is a long-awaited study. And it's a frontline study of Nivo plus IPI compared to physician's choice of either sorafenib or lenvatinib. We know it's a positive study. We're going to see how positive and what ways it's positive. So that's going to be on Tuesday with Peter. And we'll see if there's going to be another frontline option. And then, as we briefly talked about earlier, biomarkers, we've mentioned it a few times. If we could figure out which patients would do best with VEGF inhibition, which patients would do best with a CTLA-4 antibody, which patient would do best with just a single agent PD-1 or PD-L1 inhibitor, and which patients would do best with not using immunotherapy and just doing lenvatinib. There's a nice paper by Dr. Andrew Zhu and the team from I Am Brave 150 in Nature Medicine, and then some nice posters here at ASCO 2024. So I will pass it over to Peter to talk about patient-reported outcomes, a really important topic for our patients and for us.
Yeah, we decided to integrate patient-reported outcomes in our presentation as they are typically, at least to some extent, neglected. What are patient-reported outcomes? They are the report of the health status of the patient, which is not filtered or where there's any interpretation. No, it's the voice of the patient. Do we need that, or do we know it anyway? We need it because both we, but also our patients, are not extremely good in reporting symptoms. We, as physicians, we just have no time, and we don't ask questions systematically, and we ask what we know. We ask for specific side effects, and others which are maybe not so common, they are overlooked. And also the patient is not doesn't like to talk about some kind of intimate things, and is also worried. I mean, if he presents with very strong side effects, the doctor might stop therapy. So that's something you don't want. So in the end, all this results in a neglect of patient-reported symptoms and outcomes. And it has been reported that up to 80% of the symptoms in patients receiving cancer treatment are overlooked. So it's remarkable. But it's relevant because it's relevant in clinical trials to decide if you compare one substance with another, which is better tolerated. It's relevant for the routine decision-making in the clinic. It's actually for approval maybe relevant. And it's also for the patient relevant because the patient, if he does it in a structured way, or she, is able to report and to think and to compare. So it plays a role, and if you do it, then you can compare, for example, with baseline, and you do it for your treatment arm and your comparator. This is a heat map where red means there's a deterioration and blue an improvement compared to baseline. And going through different trials that may add and help in decision making, hearing the patient's voice. Just a few data from the relevant trials here from Himalaya. If you take, for example, appetite loss in STRIDE, 12.6 months, so there was a time it took until there was a median deterioration. And sorafenib, it was only 6.9 months, so half or double if the way you look at it. So that is making a difference. And fortunately, with the immune-based therapies, and the same holds true for IMPRAVE150, Atezo, and Beva, here the symptoms, that is in favor of the immune oncological agents compared to TKIs. And this is contributing to the success of these regimes, that their patients develop symptoms later and have a better maintained quality of life. So I'm pointing this out because I think it's really important. There's very good evidence that quality of life measures are important, but we neglect them. And if you use them, they are typically only secondary outcomes. But in the end, I mean, particularly in a palliative setting, it makes so much sense. I mean, you can patient tolerate a lot if you cure the disease, but if you don't, and in the majority of the cases we don't, then you have to pay attention to what is important, and it's the patient who is important, not the tumor. So this just as a few remarks on patient-reported outcomes.
Thank you, Peter. Okay, now before we move on to intermediate and early stage HCC, we'll do one repeat of the case that we talked about in the beginning and do a few permutations on it. So again, this is a 66-year-old patient with chronic Hep B and has post-TACE progression on MRI and is moving towards systemic therapy. So Stacy, for this patient, let's say she had an EGD with varices that were grade 1. How would you choose what first-line therapy to use?
Yeah, that's a good question. So, because this comes up often, right? It's not often just a completely negative EGD or necessarily grade 3 and high risk of bleeding. I often do ask the hepatologist, right, do you think this requires intervention? If we put them on a beta blocker, do you think they'd be okay to treat in a couple of weeks? And I really rely on their interpretation too of risk of bleeding. Often with very small varices, and if they hadn't already been on a beta blocker and they think that they could be controlled by that, I don't think it's an absolute contraindication, for early. But Peter, what are your thoughts?
Yeah, I like your approach to talk to the gastroenterologist because it makes a difference. I mean, varices are not just varices. If the patient is dehydrated, you won't see them. And if for some reason you scope the patient head up, you don't see them. So there are various ways to influence, and then it's just one piece of the information, platelets and history of bleeds. So there's a lot adding to it to come down to a risk assessment where you say you can do it or you can't do it. But we are typically taking those patients seriously, scope and ligate relatively early and keep them on beta blockers. And that's a decent way. Those patients where you are unable to control the bleeding risk are not good candidates for therapy anyway.
And how about impacted HCC etiology? If someone has metabolic syndrome versus Hep C, does that impact what choice you make, Peter?
Definitely not. There has been this interesting Nature paper from the Heichenwälder group claiming that immune therapy is not working in a fatty liver. But that was based on solid preclinical data and not solid meta-analytic data. And if you go through the list of clinical trials and see what was the subgroup analysis with respect to etiology, hepatitis B, C, and and a fatty liver, then it's like flipping a coin. If you take Iron Brave 150, there seemed to be a signal that fatty liver is not responding. And however, in the Himalaya trial, the fatty liver was responding well, and hepatitis C, for some reason, was not responding well. So these are heavily biased data and subgroup analysis. Unless they are proven in a prospective trial, they are not in any way meaningful with respect to decision making. So no, I would not take etiology as a underlying informative approach for therapy.
I fully agree. I'm going to throw number 2 to you as well. So something that comes up in oncology clinic all the time is if someone has grade 2 varices or grade 3 varices and they get banded, do those patients, are they okay for starting immediately on Bev? I know our hepatologists often want to bring people back 4 weeks later. So if people get banding, what's your recommendation around Bev?
Yeah, you need those 4 weeks. I mean, you can't, I mean, particularly the time post-banding, that is a time with increased bleeding risk. So here you should avoid BEVA.
So if people have grade 2 or grade 3 varices, they get banded, maybe pushing those patients more towards durvalumab for safety. Yep. And any other safety considerations you think about? I think we spoke about a few of them.
Yeah, I mean, I guess, well, we haven't talked about, anticoagulation or prior stroke or other cardiac events, right? If they're on antiplatelet agents, these are all increased risk of bleeding, even in the absence of varices. Not necessarily absolute contraindications, right? Or just history of bleeding, on these medications prior. And again, not necessarily variceal bleeding, but any bleeding events. So, things to think about. And again, we talked about, immune therapy indications and things, but I don't think there's really anything.
So you're predicting some of the question in the next
right,
one. So
right.
Stroke in the last 9 months. I think on the Iron Brave study, it was no cardiovascular accidents in the last 6 months. So if you have someone that had a stroke 9 months ago or had an MI 9 months ago, would you default to durvalumab or use durvalumab primarily anyway? Or because these patients were still included, would you more shift towards atezo-bev? Do you have a preference when someone's had a stroke recently?
I mean, I guess I would still be thinking about their performance status and what I thought the risk of a future event was, because I think, right, not everyone who had a stroke 9 months ago is the same in the same category. So I think, again, after talking to their neurologist or cardiologist, if they felt like the future risk was kind of with the treatment that they're on closer back to baseline, I'd feel more comfortable versus someone that they thought was at maybe higher event or having difficulty with compliance with some of the medications they're supposed to be taking. So I think it's depends on the person.
Absolutely, it's debatable. I mean, if that stroke was a result of atrial fibrillation and that was taken care of, no worries, go ahead.
Right.
Even after 3 months. But if the carotid stenosis is still there, be careful.
Yeah, absolutely. Nuanced decisions, and always good to be able to phone a friend easily. And then how about for Child-Pugh B, Peter? Do you give atezo-bev for B7? Do you give durvalumab for B7?
Yeah, so data are not there. What we know from the old days with sorafenib, that was in the Gideon non-registrational data, part of the Child-Pugh B patients did very well, tolerated and showed efficacy, about 25% or so, but others did not. It's clearly prognostic. Child-Pugh B is bad, and they on average don't tolerate. And we had the Checkmate 040 data. Nivo was also quite effective in a small proportion. But it's probably all about patient selection, and B7 is not B7. So if there is ascites, forget it. Don't do it. But if there has been slightly lower albumin for some time and it has been controlled, so it's debatable. But yeah, it's a higher risk, and the likelihood of success is poorer.
I mean, I think the majority of the patients I see are Child-Pugh B, so I treat most of them the same. And also, I think, right, as you said, B7 is not always the same across groups. I think some of it is the delta, were they A5 and now B7, and now you think they're going to be B8 by the time they come in for the next visit? Or have they been stable for a while? I mean, I have a lot of patients on combination immune therapy who are past 7. And a lot of them have done well for long periods of time. So it's given me more confidence to continue, to treat in that group. But it's always nice when there's more data kind of supporting that.
There is a study going on right now in patients with Child-Pugh-B with atezo-bev or atezo to see if we can generate some data to have some prospective data and safety data. So before we move on to the next section, last question is older patients. If someone was 81 and a healthy 81 versus a frail 81, does that make a difference for you?
I'm still pretty aggressive about treatment.
Yeah.
And, for GI medical oncology, our average age is kind of we see a lot of patients in their 80s. And I think it depends what their goals are and what their support is, and, making kind of an informed decision together. But I don't see that as an absolute contraindication.
The older I get, the less I feel
it sounds
age
younger.
plays a role.
Right.
Okay, so in summary, overall, if someone is a candidate for checkpoint inhibitors, we try to go with dual checkpoint or atezo-bev. If they're not a candidate for combination, then a couple of options for single agent, PD-1, PD-L1 inhibitors. And then, of course, we have these TKIs. So as you could see from the conversation today, there are lots of factors that go into this. But we're very lucky that we have 5+ options now for patients. I'm going to turn it over to you, Stacey. We have probably about 25 minutes to talk about early stage and intermediate stage and second line.
Yeah. So what do we do second line? So we'll start with a patient case. So this is a 60-year-old patient with BCLC stage C, Child-Pugh-A, HCC, and they receive atezo and bev in the first line and have progression. So what would we consider as sequential therapy, and what information do we have to guide things? So I love how complex this slide has become, because literally when I graduated fellowship and started at Yale, under C was just one word, sorafenib. That was it. And we were right next to palliative care. And so this is like amazing to me. But so we do have, data now in second line, and we'll talk about the other TKIs and other immune therapy and ramucirumab. So just to keep in mind, right, these studies were done post-sorafenib. So do they really necessarily answer the question about what to do after atezo-bev or what to do after durva-tremi? No, but in oncology, we love to extrapolate. So this is what we do in this case. So we have the regorafenib data from the RESOURCE study that was randomized to placebo after sorafenib, the Celestial study that looked at cabozantinib versus placebo. And then there was the REACH and then REACH2 study that looked at ramucirumab versus placebo. So obviously the bar was very low when these studies were done for placebo-controlled studies. And they all showed, a small median overall survival difference with also relatively small, progression-free survival benefits. But there was an improvement, in survival. And to keep in mind the REACH2 study. So the REACH study had looked at ramucirumab versus placebo, and it wasn't a positive study, but it looked like there was a signal in patients with a higher AFP with a cutoff of 400. So the study was done again, focusing on that patient group. So the ramucirumab indication is for patients with an AFP of over 400. And so then we also have some data in second-line approved immunotherapies. And I just want to mention again, these studies were done before the approval of atezo-bev. And so, this is in the post-sorafenib, arena. But there was data with nivolumab as single agent, pembrolizumab as single agent, or the combination of IPI and nivo. And so I think then, the question in this setting really becomes, what do we do with this second-line data set if a patient is receiving atezo-bev or durva-tremi in the first line, right? And I think that's something we really don't know that there's necessarily a benefit in doing, but we'll talk more about that too. So where is the future headed for second-line treatment selection post-IO? So if we have a patient who's 60 with BCLC stage C, Child-Pugh-A, HCC, received frontline atezo-bev, right? What are we thinking about in terms of sequencing therapy? And I'll ask you, Lipika, what do you usually do post-atezo-bev? And does it matter how long they were on atezo-bev or how they tolerated it?
Yeah, so one, I think about, are they a candidate for a clinical trial? Two, I think about, is it time to send them back to IR because atezo-bev shrunk the tumor in some way, and now we can think about doing liver-directed therapy. And then three, if I need to use some sort of standard systemic therapy, then I think about how did they tolerate the IO and how did they tolerate the BEV, and then accordingly think about potentially durvalumab next, or think about a TKI such as lenvatinib or cabozantinib next.
And does that change at all if it had been first-line durvalumab?
Yeah, then I feel better about using a VEGF inhibitor second. And so then I would think about atezo-bev second, or I would think about using something like lenvatinib or cabozantinib second.
And do you have data driving the atezo-bev as second line?
There's a small series of big retros.
There has been a Japanese trial where lenvatinib was used as first line therapy and atezo-bev in second line. And the data is small numbers of patients, but the data with respect to PFS and OS were comparable to first line. Maybe it's similar to colorectal, just do what you want, but you should get these different lines together in the end. Yeah,
I think the hard part, right, is you can't redo all of these studies now, and that really doesn't make sense in terms of effort in the field, right, to just kind of repeat these studies after current first-line therapy. So, I mean, this is not an uncommon issue to kind of think about in oncology. So when we think about, selection of second-line therapy, if we're starting first-line therapy with atezo-bev or durvalumab or single-agent durva, right, then we have a TKI as an option, potentially combination IO therapy. And we don't really know, right, we don't have strong data of a randomized study to say that sequencing the different IO combination therapies necessarily gives a survival benefit. When first-line therapy is with sorafenib or lenvatinib, which often is because the patient was thought to be really not a candidate for immune therapy, but we do have cabozantinib and regorafenib as options, and then single-agent antiagenic therapy like ramucirumab. We have also IO therapy, and this, again, often happened when there was approval of these drugs first, right? We went in the reverse order, and I guess theoretically there's, the possibility that for some reason it was thought that someone wasn't a candidate for IO at the beginning of their therapy, and then the decision-making may change. But I think this isn't a typical sequence. And of course, we have, the supporting data from the studies that I mentioned. So now thinking about, combining multimodal therapies for advanced HCC, is there a role for combining local therapy with systemic therapy? So we'll go to a case of a woman who's 66 with hepatitis B and a new diagnosis of HCC. She has good liver function and good performance status, normal bilirubin creatinine, and her AFP is elevated to over 4,000. On the imaging, we see an 8-centimeter tumor with right portal vein thrombus and lung metastasis with an EGD with grade 1 varices. So, Peter, do you think at this point for this patient's presentation, is there a role for multimodal therapy using potentially local therapy and immune agents in this setting where there's some metastatic disease?
This is actually a nice slide to come to one of the questions from our audience. Does launch raise questions about an expanded role for LRT in advanced HCC settings? So exactly what we are just talking about. I mean, evidence-wise, this is not so clear or so well studied, but we can accept that launch, which investigated in an advanced stage setting, patients treated with lenvatinib, either alone or with respect to a combination TACE added to lenvatinib. And the data are actually quite convincing. So that is an option which is in individual patients used. And we haven't been talking about the aspect of therapeutic conversion. We do have patients where we get started in a palliative setting and try to complete responses by local ablation, for example. So the evidence here is a bit sketchy, but it's doable, and in some patients, as a result of MDT discussion, an option.
Yeah. So perfect. So I think those are some great points. I just wanted to mention, we think about pattern of progression in patients, right? So progression is not the same for all patients. We're thinking about intrahepatic growth, extrahepatic growth, whether when a new lesion pops up, is it in the liver? Is it outside of the liver? And I think all these things really do matter. And as Peter mentioned, there was the launch study that looked at adding lenvatinib to TACE. So this isn't necessarily thinking about immune therapy, and we don't, this just looked at lenvatinib. But what was interesting is that there definitely was a survival benefit, and you could see a nice separation of the curves, in terms of overall survival. So what did we get from adding, local therapy in this situation? It could be that the driver, of progression was in the liver, and that by controlling a large tumor in the liver, patients don't typically pass away or have complications from small pulmonary metastasis. And so that really making a difference in the primary tumor could still be making a significant survival benefit. I think what's hard to know, for me, at least from this data, is, would this be the same benefit, right? Kind of, can you take this data and necessarily think about immune therapy in that setting? But fortunately, there's other studies that we'll talk about in a few minutes. So just to kind of think about this, I think that often patients will receive local therapy, and usually that's earlier in time. But often, as we talked about before, we do move back and forth. And so, for instance, if someone's been on a Tiso-Bev and it's been well over a year, and then they just have progression or one new lesion in the liver, but everything else is controlled and they're overall doing well and tolerating it well, that's often a patient population that we would think about adding in local therapy to control the one area of progression, which is not the same as the launch trial. But I think it just shows that we're very kind of comfortable with moving back and forth, that way. I think, these unmet needs are, very clear that we don't really have a good way, right? We don't have biomarkers for any of this decision-making. And then when patients have resistance to immune therapy, right, is there something else that we could do that would, impact that? And a little bit more thinking of sequencing therapy, where the second line is really informed by what we give now as updated, first line therapies. So in this patient that we had just presented, who has minimal metastatic disease, I think we kind of reviewed, right, what we would take into account, where the progression is, right, where the bulk of disease is, and what we think would be compromising their survival most. And I think it's reasonable to, in certain situations, to think about adding local therapy back into systemic therapy.
Which gives me the chance to talk a little bit more about local regional therapy in the intermediate stage. I'd like to remind you that local regional therapy, intra-arterial therapy, TACE, was established at a time where we had no systemic therapy. And that results in the question, what is the role of systemic therapy in that stage? Let's again talk about a patient here, unilobar multifocal disease, no macrovascular invasion, no extrahepatic spread, so a large tumor, but confined to the liver. What's the treatment options we have here? As I said, intermediate stage HCC is heterogeneous, and it is very likely that not one modality is the optimal way to go for all these different patients with a low number of tumor nodules and a small size or a large size. And one issue which we learned in the past was that you might interfere with subsequent therapies. Don't forget, intra-arterial intervention may spoil blood flow through the liver, may come at a price. You lose liver function, and patients are no longer fit for systemic therapy. And we know systemic therapy is working, and it's actually working well in BCLC-B patients. For example, in the Iron Brave 150, I think 15% or so were of that category in the BCLC stage B. So that is an ongoing discussion. We have the standard recommendation TACE, and in the past when we had no systemic therapy, it was all TACE, and now systemic therapy is getting better and better, and that is shifting local regional therapy a bit more to the left. There are various ways to predict whether TACE works, but I have to say, I've never found all these scores. I've never found the way into guidelines. And they are descriptive, and of course, patients should be in good liver function, good performance status, good kidney function, and certain complications such as bleeds, ascites, really are preventive with respect to interference with the arterial blood flow. And then it's very simple. The larger it gets, the poorer the prognosis. So these are all data we integrate in our decision making, but again, prognostic scores have no role in clinical reality. This is a picture from Masatoshi Kudo from Kinkai University, and it's again the simple summary that the higher the tumor burden, the less the response. And there's an unclear threshold where you have to decide whether you go for TACE or for systemic therapy. There have been retrospective data, and they, for example, compared TACEable patients who received either TACE or systemic therapy, lenvatinib, and in this trial, it was actually in favor of the systemic therapy. There are trials which challenge indeed TACE in intermediate stage. That is the REPLACE trial and the ABC HCC trial, where we ask the question whether TACE or systemic therapy is getting down to better outcomes. That is not yet in any way answered by any trial. We just don't know how good the performance of systemic therapy is. In the past, we had a different approach. We were accepting TACE as standard of care, and we didn't want to spare patients from this therapy, and we added additional systemic therapy. It started with the SPACE trial, and in the SPACE trial, sorafenib was added to TACE, but the data with respect to time to progression were very comparable. A trial from UK, TACE2, again, extremely similar data. TACE or TACE plus sorafenib, no difference. The TACTICS trial was using a different endpoint, time to untaceable progression. That gave some positive results, but in the end, that was an unclear situation. It has changed now from as of January 18th, when the EMERALD-1 data were presented at ASCO GI. That's a trial where TACE was used either as monotherapy, arm C, or received durvalumab and bevacizumab or durvalumab alone added to TACE. Most patients received one or two TACE procedures and then and durvalumab, and then bevacizumab was started 1 week after TACE. And indeed, there was an improved progression-free survival. Actually, the absolute difference from 8.2 months compared to 15 months when patients had durva and beva added to TACE was quite remarkable. The hazard ratio, okay. And with respect to the side effect profiles, we have also a report here at ASCO, it was manageable. There were side effects added by the addition of Dova and Beva, but it was in the end not unexpected and consistent with previous reports. So we are now in a situation where that regimen is adding to our armamentarium. We know now that systemic therapy plus TACE may be beneficial for the patients, but what we don't know is whether the old sequence, you start with TACE and then you go to systemic, and that comes to a certain outcome, whether this is outcompeted by this new regime. So we have more questions than answers here. What do you think, Lipika? Is TACE alone the best option for this patient? There was a heavy tumor burden. Or already an essential to use Emerald?
I think the Emerald-1 data are really encouraging. We're really excited that there's now these multidisciplinary trials that are showing positive data. It's very encouraging that the PFS looked like it was significantly prolonged, not by a month or two, but really more than that. I think the question, as you're saying, is in the end, are we just delaying time to progression? And overall, if you sequence it, are you going to have the same overall survival, or are you going to actually significantly cure some of these patients early when you combine it with TACE, and then you're actually going to meaningfully change overall survival? So I think it's definitely a conversation with patients, especially people who have high-risk disease. It's worth talking to people about whether or not they want to use the Durva with the first dose of TACE and then use the Durva-Bev after that. And obviously, it's a conversation with the interventional radiologist if they're willing to coordinate and do that. But I think also we look forward to seeing the more mature data for it.
Yeah, and there's more to come, and I will show you that. So it will be getting more and more complex. ML3, Dova, Tremi plus minus lenvatinib, so even more systemic therapy, that will be an option. We expect relatively soon LEAP-12. This is the combination which had been used in the LEAP-002 trial, which was a negative one, Lenva and Pembro. And here is added to TACE. It's an interesting protocol because it's different from the Emerald-1 in that lenvatinib as VEGF receptor inhibitor is used more or less throughout and in the beginning, whereas Beva is after the TACE intervention. So it's a different trial. It will be interesting to see what data are coming out there. And then that has been, you're aware of that, frequently discussed, that if you create damage in the tumor, you shed tumor related antigens. That might be an ideal setting. Use TARE, SEART, and add systemic therapy in that immune stimulated situation. And here, just a list of ongoing immunotherapy trials with LRT. So the discussion, systemic therapy versus TACE, TACE plus systemic therapy is an open one, and it will be definitely interesting in next upcoming years what is coming out here. And the end of the story, we had advanced stage in the beginning, intermediate stage, and now early stage disease.
So Stacey, stick with me. I know we're almost done, so I'll be quick. But I think this is important, and I think an exciting piece to end with, because this really, we're thinking more about early disease, which is exciting. So this is a case of Ronald, a patient with extensive microvascular invasion at the time of resection. So this is a patient with a history of MASH cirrhosis who had a large unifocal HCC and had resection and was found to have extensive microvascular invasion and moderate to poor differentiation. And so the question is, how would you treat this patient? Would you give adjuvant therapy? And it's interesting. So we know that patients fall into different categories, right, of how likely they are to respond to immune therapy, but we really don't put them in these categories. So, it's interesting to think about different gene expression signatures, but let's be honest, most of the patients that we're treating, in later stages, we often don't even have a biopsy on, right? So we don't really have this information on most of our patients. But we know that some patients are more likely to respond than others, and there's certainly rationale for using anti-VEGF agents with IO. We know from the phase 1 study of atezo-bev that if you give atezo alone, the response rates are more like other, single agent Nivo or Pembro, and that certainly there is a synergistic effect between giving these two drugs. That's not just additive, right? And so we're creating an environment in the tumor, right, that's more likely to respond to immune therapy. So, we certainly have a flow diagram here of who goes to surgery. And of course, our surgeons are very involved in our multidisciplinary discussions at tumor board. And, they have guidelines for who's a good resection candidate. Often they're thinking about, of course, not just the tumor characteristics, but the overall health of the liver and the patient. So they're thinking about portal hypertension. And there's just a few, parameters here that they think about. But of course, another important piece is that we have to leave a certain amount of functional liver behind, right? And that amount changes depending on how healthy the liver is. And then after surgery, right, the only study that had been done previously was looking at adjuvant sorafenib, which was a negative study. So the current standard of care for years, right, has been to just follow with surveillance. But now we have several ongoing phase 3 studies that are looking at adjuvant immunotherapy, right? And so they have different inclusion and exclusion criteria, but overall, they're trying to focus on a group that we're concerned is going to recur. And interestingly, for most of these studies, you could see that the primary endpoint is relapse-free survival, which certainly we could debate. There's one study that has a primary endpoint that's both relapse-free survival and overall survival. And of course, the study IMbrave 050 has already been reported that looked at adjuvant atezo-bev for a year versus active surveillance, which is the standard of care. And basically what we see is, if you look out to the first bar going down is our 12-month endpoint, right? So this is where the treatment stops. And then you could see that within 6 months of stopping, there's still a little bit of separation of the curve, and then it kind of crosses back. And so it looks like, we're preventing recurrences for a certain period of time in some of the patients, right, for months. But then after the treatment ends, things are kind of going back to baseline. And so the question really is, what is the change that we've made for these patients, right? The patients that are in the separation of this curve. Does that change justify giving them a year of immune therapy? Are we improving survival in some of these patients? Does this justify giving the drugs for a year? And I think that's certainly debatable. So the study was statistically positive, but I guess I'll ask the group here, has this changed your practice? Has this data affected your practice?
It's definitely a conversation that I have with all of my patients with high-risk disease after they have surgery. I would say that it's similar to the EMERALD-1 data in that it was an RFS difference, serious comparable to a PFS difference and not an OS difference yet. And for the same things you're saying, are we just delaying recurrence or are we actually curing people? So for people who are high risk, I certainly talk about it, and it's a conversation. We look forward to seeing the subgroup analysis, even though, as Peter said, these are not powered to definitively make clinical decisions, but it can certainly, if there's a big difference in certain subgroups, certainly worth adding to the conversation with patients.
Yeah, in theory, HCC with the very high recurrence rate is an ideal tumor for adjuvant therapy. But these data are not mature enough. And that was actually the conclusion in the Lancet Oncology paper. So we have to wait for more mature data, hope that the curves separate and it's true reduction of recurrence and not just a delay. But we have to wait. Absolutely.
So again, if we have a patient, right, with extensive microvascular invasion and poor differentiation, we can think about this data set. But I would say that I'm I think, we have different conversations with patients when we think something is clearly in their best interest to do and when it's really more of an open discussion. So I think what people are often doing in this setting now is to really kind of, if they're very concerned that the patient's at high risk, discussing the data, kind of discussing the pros and cons of doing it, maybe potentially offering it. But I think it really has to be more of an informed decision, maybe understanding that this isn't necessarily, we don't know that it's necessarily going to translate right into a higher rate of cure. And so just to mention that, we do have other studies ongoing in the perioperative setting. And so we're not really discussing any trial in particular about neoadjuvant therapy, but that's another exciting avenue of giving patients who really are candidates for resection up front, treatment prior to their surgery. There are some small studies that have shown a lot of tumor necrosis after surgery, but we don't know if that necessarily translates into more long-term survival. But I think that this is really exciting and, potentially of benefit. So we'll have more trial data, coming up in the future. And I think this is another important avenue where we could really potentially make a difference in cure.
I'm a big fan of neoadjuvant therapy. I mean, there are two basic reasons. One, you are treating an existing tumor environment, not taking out the tumor and then treat. No, you treat where everything is there. And you get, when you then do the resection, the result of your therapy. So you learn something. So neoadjuvant is great.
So, I think that's a very interesting issue, right? Because the question is, what is bevacizumab doing in the adjuvant setting when there's no measurable disease, right? Like, because there is no tumor environment in that setting necessarily the same way. It's just kind of possible very small amount of residual disease. And you could imagine you can't get the same benefit.
Tackling VHF is always good.
So lots of exciting things, I think, coming down the pike.
I mean, I think you all believe that immune therapy in combinations is the way to go. And however, what we truly lack are biomarkers and predictive information. We know a lot about prognosis, but we are unable to predict therapeutic response. And that would help so much. And it's a bit of a pity because if you think about signatures with prognostic relevance have been developed almost 20 years ago. Lee from the Thorgan group showed a picture with great prognostic value. Nothing had made it with these tons of signatures into clinical decision making. So that is the lack we have. And however, what is optimistic about today's information is that we see that so much more in systemic therapy is there, and it's shifting constantly towards the left in the BCLC scheme to intermediate stage and early stage disease. Maybe I have 2 or 3 more minutes to ask a few questions which have been forwarded to us. One which I like is what is the role of radiation added to immunotherapy in HCC? SBRT, helpful, not?
Yeah, there's really trials ongoing right now, both with atezo-bev and with durva-tremi in combination with radiation to see how those can synergize. And we certainly use a lot of radiation in HCC, both as bridging to transplant in patients who are no longer transplant candidates and have portal vein thrombosis. So we work very closely with our radiation oncologists in our multi-conference.
A question by Charles. Have you ever re-challenged a patient with a TKI or IO regimen in later lines of care after they had been exposed in earlier lines? So do you reinstall sensitivity?
No, I think that's an excellent question. I mean, I don't know that we know the answer to that. I could think of specific patients that have been in different situations for one reason or another that we had to stop therapy, and I considered re-adding it, but I wouldn't say that we really have an algorithm for that.
But there have been indeed a couple of cases described where the progression occurred given a IO regime. Patient was put on a TKI, and then the same regime was applied again with success. So it is possible, and it's probably all about immune modulation rather than the individual agent. How many cycles of TACE would you give patients, and when do you combine with systemic therapy? 2 questions at once.
Yeah. It's a good question. I mean, I think a lot of it has to do with timing. I often use the analogy, and this is kind of a pretty rudimentary analogy, of the game at the boardwalk of whack-a-mole, where, you know, something comes up and it happens slowly at first. So you feel in control of the situation. There's one thing that pops up, and then another thing pops up slowly. But then all of a sudden 2 things pop up, and then it starts to happen faster, and then you definitely feel like you're out of control and lose the game. And so I think a lot of it depends on the timing. You know, when there's one lesion and then a year later there's a second lesion in a different location, that feels very manageable. And the pace really seems to suggest that you can continue to control with local therapy. But when there's new disease at each new scan, right, and then there's more than one, I think, you know, now that we have better treatment options, I think everyone, including the interventional radiologists, feel comfortable, you know, kind of going past TACE. Now, there's a question of, you know, who do you give radioembolization to? But I think when you start out with TACE and all of a sudden there's more lesions in a faster time period, I think what's hard is that it's hard to create a definition for that, which is why I think tumor boards are so important, because we really have to go through each patient and all the longitudinal scans to really have a sense of the timing and pace, and someone presenting what's actually going on with the patient who's met them and knows them. And then I feel like we could make an informed decision.
You're tasting time to be out on route.
Yeah, I agree with Stacy that their tumor factors, their liver factors, and their patient factors that determine how much TACE you do and when you move to systemic therapy. And with the tumor factors, it's just as Stacy is saying, is in terms of timing. I have some patients who for 7 years, the IR doctors are doing different kinds of ablation and Y90 and TACE, and they never have to come see me. And I think that's success, because I don't want patients to come see me and feel like a patient, see me every 3 weeks if they can just get a TACE every several months or, you know, twice a year and do well. So those are like the tumor factors. And, you know, is it bilobar? Is it spreading outside the liver? Is there portal vein thrombosis? And the liver factors, this is what Peter presented with the prognostic scores. I think this is a really big change in the way IR and MedOnc interact. When I was a fellow, you know, we would just have IR do as much as they could for as long as they could, because as Stacy was saying, sorafenib's not as effective and it's not that well tolerated. It did its job for a long time, and that's great. But now that we have many more effective therapies, I think the IR folks are sending patients to MedOnc earlier before the liver function deteriorates, so they have a chance at getting drugs like durvalumab and atezobev. And the patient factors, you know, people who live 3 hours away, if they don't have a specialty onc center near them that has familiarity with immunotherapy, then it can be tough for them to get systemic therapy. And so if we can string their tumor along with just treating with liver-directed therapy every several months, that might be better for that patient. So I think it's a couple of different things.
That sounds like a good summary. Stacy and Lipika, you were wonderful faculty.
Thank you, Peter.
Thank you all. Have a good evening.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, Blue Faery, the Adrienne Wilson Liver Cancer Association. This educational activity is supported by independent medical education grants from AstraZeneca, Bristol Myers Squibb, ASI Incorporated, Exelixis Incorporated, and Merck & Company Incorporated. To access all materials for this activity, visit peerview.com/VXT860.